Hello, my name is Kara Browning, and today I'll be talking with you about osteoarthritis. So, osteoarthritis is actually a result of a loss of articular cartilage. And your articular cartilage is actually made up of chondrocytes, collagen, proteoglycans, and water, and they cover the end of your joints. And they help with the normal gliding motion that you have when you extend your elbow or your knee or your hip or something like that. So the articular cartilage is actually lost due to a cascade of signaling, cytokine, and anabolic growth factor pathways. The chondrocytes are the cells that are present in the cartilage, and they typically maintain themselves through normal anabolic and catabolic activities. But as osteoarthritis develops, those chondrocytes begin to proliferate like wild, and they actually go into overdrive. And this causes an excessive breakdown of the proteoglycans, glycoaminoglycans, and collagen. And this cartilage has only a limited capacity for repair, and eventually too much collagen is lost, and the cartilage is not sufficiently replaced. So in osteoarthritis, because of that excessive chondrocyte proliferation and inability to replace itself, the surface of the cartilage starts to flake away, and it causes the deeper layers to develop these longitudinal fissures, which is also known as fibrillation. And as this disease progresses, that articular cartilage becomes very thin and even completely just is gone over some areas. So this leaves the underlying bone unprotected, and that causes the bone in that area to become dense and hard. Cysts begin to develop on that unprotected bone, and they actually erode through the remaining articular cartilage, causing osteophytes to grow. As these osteophytes grow, they grow outward from the exposed bone, and they cause the joint anatomy to be altered, also causing deformities in the bone. Eventually, these bony projections actually break off into the synovial cavity, and it causes joint effusion and synovitis. That's actually where the majority of the pain comes from. When a patient has osteoarthritis, it's related to the synovium inflammation rather than the actual damage of the articular cartilage. And over time, the joint capsule thickens, it can adhere to the deformed underlying bone, and this causes the patient to have a limited range of mobility in the joint that's affected. So in the management of osteoarthritis, you want to take a holistic approach, as with any patient that you're dealing with. So you want to assess what their knowledge of osteoarthritis is, what their quality of life is, and how their osteoarthritis is affecting their quality of life. You want to know what their aspirations are and what they do on a daily basis. You know, do they play golf? Do they like to play tennis? Do they have grandchildren that they're trying to keep up with? And how does osteoarthritis restrict, what they can do on a daily basis? You also need to know if their pain is causing sleep disturbances or even distress on a daily basis. You also want to assess their fall risk assessment and see if they're at risk for, tripping, falling, and causing further injury. You also need to determine if they have further social support, whether it be a spouse or children, if they have other comorbidities, and what they're really expecting from their treatment plan. And also if the patient has any modifiable risk factors, which we'll get into in just a little bit. So the goal of osteoarthritis management is to really optimize the patient's function and minimize their pain. It's to reduce the process of joint damage. So typically in osteoarthritis management, the first line of defense is always non-pharmacologic. So basic things that you can do are discuss weight management with the patient. Are they obese? Are they overweight? By how much? And that's one of those modifiable risk factors that they can change. Another thing is exercise. Does your patient exercise on a regular basis? What type of exercise is it? Because this is another modifiable risk factor. The other thing that they can do is use braces or some sort of like foot insertion on, their shoes or things like that. This is really only suitable for certain types of patients though. And then the last thing that you want to do is obviously educate your patient. The more that they know about this disease, the better equipped they'll be to handle its management. Pharmacological management for osteoarthritis should really be used after non-pharmacological therapies have been tried. These pharmacological therapies have not been shown to modify the disease process. They're only intended to really help with the symptoms that occur due to the presence of osteoarthritis. So the first line of defense that you're going to use are NSAIDs. You would like to, if the patient only has a few affected joints of osteoarthritis, try and stick with the topical NSAID. They actually have similar efficacy when they're compared to oral NSAIDs. If that's not managing the patient's, pain, or if they have multiple joints that are affected by their osteoarthritis, then you can consider an oral NSAID. These include ibuprofen, naproxen, diclofenac, and of course celecoxib, which is what you would use for patients that are at risk for a GI bleed. So these really should be used as needed due to the adverse effects that occur with NSAIDs, which we'll talk about later on. Another pharmacological treatment that you can use is duloxetine or Cymbalta. They think that duloxetine affects the pain inhibitory pathways through the inhibition of serotonin and norepinephrine reuptake. And then finally, you can also consider some intra-articular glucocorticoid injections. These are really only reserved for those that have moderate to severe pain and have failed other treatment options. They really only provide short-term relief of about 6 weeks. So next we're going to talk about some of the side effects that can occur with different pharmacological interventions. So first we'll talk about NSAIDs. Dyspepsia, peptic ulcer disease, these are common things with this medication. And if it gets bad enough, it can cause a GI bleed. It can also cause some acute renal failure if the dosing is too high, and that leads to electrolyte imbalances. There's also an increased risk for myocardial infarction and an increased risk for stroke. There's also risk of hepatic injury, worsening hypertension, and tinnitus. Patients should not take NSAIDs if they have a significant history of peptic ulcer disease, Barrett's esophagus, uncontrolled hypertension, severe kidney disease. Also, if they're in the 3rd trimester of their pregnancy, NSAIDs should be avoided. Or if the patient has severe coronary artery disease or any type of hypersensitivity to NSAIDs in the past. Pharmacological side effects of duloxetine include weight loss, abdominal pain, decreased appetite, nausea, vomiting, drowsiness, fatigue, and headache. The patient should not take duloxetine under any circumstance if they are taking a monoamine oxidase inhibitor. Even if they stop the monoamine oxidase inhibitor, they still shouldn't take duloxetine for 14 days. Other contraindications for taking this medication include the patient having severe hepatic impairment, severe renal impairment, or again, a hypersensitivity to duloxetine in the past. Finally, we're going to talk about the pharmacological side effects of glucocorticoid injections. These include simple things like pain at the injection site, bruising at the injection site. There can also be thinning of the skin at the injection site. The patient may also complain of insomnia. If they're diabetic, you want to be careful with this because this could cause their glucose levels to rise as well. And also the patient may have increased appetite. You should not use this therapy if the patient has a periarticular infection, history of septic arthritis, or joint instability in the area that you would like to inject the medication. So now we're just going to review some of the literature that support the treatment plan. To start, we'll look at weight management. There was actually a study done that showed that losing 10% of body weight reduced osteoarthritis knee pain by 50% in patients that were overweight and obese. Weight loss is also one of the most important non-pharmacologic interventions of osteoarthritis, according to Huther and McCants. Next, we'll go into exercise. Strengthening exercises and aerobic exercises have been associated with knee and hip osteoarthritis pain relief. There have also been studies on water aerobic exercises for the low intensity, and some of the results are still waiting on that, but overall, it does show to provide some pain relief. When you exercise, there is improved muscle tone, and this helps kind of take some of the stress off of the joints themselves. It also can increase a patient's range of motion and stabilize their balance. For NSAIDs, in 2015, there was 137 trials that were reviewed that showed that NSAIDs were actually more effective in controlling a patient's pain when compared to acetaminophen or Tylenol. Because of this, NSAIDs are going to be the first line of defense over Tylenol. There was also research that showed ibuprofen and diclofenac were shown to be just as effective as the intra-articular corticosteroid injections in reducing pain. So it's just another emphasis on you should really try those therapies before you go straight to a corticosteroid injection. For duloxetine, trials for this medication showed to have a 30 to 50% improvement in what the patient reported as their pain when duloxetine was prescribed. As far as patient education, obviously the patient should receive education about what osteoarthritis is and how it's caused, the risk factors of osteoarthritis that they can't change, such as increasing age. Females are unfortunately a little bit more at a higher risk for developing osteoarthritis when compared to men. And prior joint injury is also another risk factor for developing osteoarthritis. Modifiable risk factors are what you should really focus on with the patient. These include if the patient's overweight or obese, if they partake in physical activity, or if their job, occupational activities are having an effect on, the joint. If they're constantly lifting boxes or doing repetitive movements, things like that, those should be reviewed with the patient so that an action plan can be made to protect the patient from further progression of their osteoarthritis. You should also make sure to include, simple things that you might not think about of, using hot packs or cold packs to assist with pain alleviation. Of course, that's in conjunction with other therapies that are prescribed. Patients know pretty well, if putting ice on their joint helps relieve some of the pain, or if heat works better for them. And there's also, you can do a combination of both depending on what the patient really prefers. And you should really emphasize how physical exercise can help strengthen the muscles, which will overall reduce the osteoarthritis pain in a patient. So yes, it will hurt up front. There's different medications that can be given to deter that pain that they'll have. But overall, later on, if they keep doing these exercises, they're really going to build up their muscle strength, and later on, it will reduce their pain. You should also explain to the patient, because a lot of patients think that the supplement over-the-counter glucosamine and chondroitin, it cures osteoarthritis, or it really helps them. You should explain to them that there is no reliable, strong evidence that supports the use of the supplement. But if they really want to try it, they really believe it, kind of like a placebo effect, just make sure that they okay it with their physician, review the rest of the medications that they're taking to make sure that it won't interact with anything else that they need to take. And then finally, it's really important to explain to these patients that it's going to take time to find the exact combination of medications and exercises and alternative therapies that will work best for them. This diagnosis is not, doesn't have the treatment option of one thing is perfect for everyone. Different combinations will work better for some patients, and other patients won't respond to that same therapy at all. So it's really important that you explain to them not to lose hope, that many people with osteoarthritis find ways to continue doing what they love to do. It's just going to take some time and some effort on both parties, the patient and the prescriber, to find a combination that works best for them. And then here are just some references for the presentation today.